Hello everyone, good evening. I am Dr. Karen Sullivan with you for another I Care for Your Brain lecture. We have been at this for about 4 or 5 months now, coming to you every week. We started in October and we've been meeting so many new people. It's been really touching to get to hear so many of your stories from all around the world and hear what it is that you want to know about the brain, and particularly different types of brain injuries that have happened to either you or a loved one. Tonight, we're actually starting off a new series, which I'm really excited about. We are starting a 4-week series in which we are going to focus on stroke. Tonight, we're going to talk about cerebellar stroke, and it's probably my favorite part of the brain, in part because it's poorly understood, and I tend to like things that aren't well understood so I can do my research and talk with people who've been affected and get a really good understanding in my mind. And it was one of the topics that I focused on when I did my board certification exam. So it is an area that I consider myself to be a respectful expert in. And I would love to share what I know with you tonight about the cerebellum, because it's actually misclassified as being an exclusive motor control center of the brain, and really it's so much more. There are certainly changes that happen after damage in cognition and mood, and we're going to talk about those in detail tonight. So the other stroke areas that we're going to focus on over the next 4 weeks are the thalamus next week, basal ganglia, and then pons. So if you know anyone that's had any of these stroke locations, I would love for you to let them know about us so that they can learn all that they possibly can. I want to dedicate my lecture tonight to a group of amazing people on Facebook who have welcomed me into their community so nicely over these last few weeks and months, and have really helped me understand on an even better level the impact of stroke on people, and that's what I care most about. This is the Young Stroke Survivors Global Network group on Facebook, and their fearless leader is Elizabeth Apple, and I hope that she's listening tonight. She told me she might tune in, so I'm excited to hopefully help her as best that I can. So I have 4 goals in mind as we start off this lecture series together. The first one is that I really want to help you understand a unique part of the brain, what it does both when it's healthy and when it's had an injury. I want you to understand symptoms through 3 different domains, so physical, cognitive, and emotional or mood or behavior. Those 3 can kind of get clumped together. But one rule of thumb about the brain that I think is very fascinating is that there are these essential 3 systems in the brain: physical, cognitive, and mood. And whatever we can see happening in one system tends very commonly to also be happening in the other system, because it's the same part of the brain that's operating the physical symptom, the cognitive symptom, or the mood symptom. But what can we see most readily? It's the physical symptoms, right? So sometimes the thing that I care most about, which is cognition and mood, they're not readily seeable. They're not readily measurable in an examination. And so these are the things that sometimes get left behind a little bit. I want to talk with you about outcomes and rehab. The goal of doing all this is to hopefully help empower you and create more compassion in the world for people living with different brain injuries. So let's get to the cerebellum. That's our topic tonight. Cerebellar strokes are actually relatively uncommon. Of the 600,000 strokes that happen every year in the United States, only about 2 to 3% of those are cerebellar strokes. Now, of course, if you are in that 2 to 3%, it's not so relatively uncommon. The cerebellum is fascinating for a few reasons, but the first fact I wanted to share with you is that although it accounts for 10% of the total volume of the brain, it actually has over 50% of the neurons in the whole brain. It's a very populated area for brain cells, and also there is a lot of myelin in the cerebellum, which really speaks to the speed of communication that this part of the brain uses. As I was saying before, it's pretty poorly understood, and it often gets stereotyped for its motor control, which of course it definitely does that, but it does a lot more too. In the last 20 years, there has been a lot of research into the cognitive and the mood symptoms. So I thought it might be good to just start off with some basic facts. Some of you might be listening to me tonight because you care about someone who's had a cerebellar stroke. So I want to just kind of take it from the top so we all get to the same page. So the cerebellum cerebellum is located in the back of the brain. I've got my handy dandy blow up brain here. And basically, some people call this the big brain. This is the cortex, and underneath all the important structures of the subcortical area. But the cerebellum sits back here, and it's sometimes called the little brain. It has a left side and a right side, which are called the left hemisphere and the right hemisphere. And it also has a top and a bottom called the anterior and the posterior. And I wanted to we're going to use visual aids tonight, which we have never done before. And hopefully this comes across well on Facebook. That looks pretty good. The cerebellum is very, very, very complicated, and there's a lot of extremely smart people out there who work on the cerebellum at the neurochemical, neuroanatomical level who could sit here for 20 hours and talk to you about it. Each one of these lines here represents a different aspect or different substructures within the cerebellum. Clinically, what we care about are the top and the bottom, the anterior, the posterior, and the left and the right hemispheres. This is what we know about best through research, is what happens to people when their cerebellar stroke is on the top, the anterior, the bottom, the posterior, or if it's on the left side, or if it's on the right side. Like I said, you could do very specific types of neuro research and get way more pinpointed than that, but that's not really the level that we're going to talk about it tonight. Like all brain structures, the cerebellum has its own unique blood vessel network, and that's this picture here. So depending on which vessel was either blocked due to an ischemic stroke or bled due to a hemorrhagic stroke, different areas of the cerebellum's blood supply is going to be affected. Typically, cerebellar strokes only happen in one of these three main blood vessels, and that's going to map onto, of course, as you can see here, that you're going to have the anterior top area that's damaged, the left side or the right side, or that posterior part in the bottom. Very rare that you actually see someone who has damage to the whole cerebellum. So those of you who are out there listening, the case is that you probably have had very specific area of damage. You might not know that, but after this lecture, you can talk with your doctor and hopefully find out more information. This is a really cool thing about the cerebellum. So the way most of the brain is set up is that the brain structure and the part of the body that it controls are crossed, right? So if you have a left hemisphere stroke, you are going to find problems using the right hand and vice versa. So right hemisphere stroke, you're going to have problems with the left hand. Well, the cerebellum is actually different. What we see for motor symptoms is that the side of damage is then consistent with the side of the injury on the body. So if you have a left cerebellar stroke, you are going to have left body symptoms. If you have a right cerebellar stroke, you're going to have right body symptoms. Now, here's where it gets super, super interesting, and this is what blew my mind about the cerebellum, is that when we start talking about cognition and mood, the opposite takes effect. So some parts of the brain have what we call doubly crossed wires, so to speak. And this is the case in the cerebellum. So the right cerebellum is connected in a series of reciprocal loops to the left frontal lobe, and vice versa. So damage in the left cerebellum is going to give you problems in the right frontal lobe. So when you have a cerebellar injury, and this really goes for all strokes, you're going to hear this throughout the whole series, you're going to have both direct injury, so that's the injury that happened in the actual structure, the cerebellum, but you're also going to have indirect effects, and these are very important to understand because you might have some symptoms that, you know, when I look up what the cerebellum does, this just doesn't make sense. But once you understand the way the brain is wired, you are going to get it so much better. And to me, that feels very, very important. If I had a stroke, if I was in your situation, I would want to understand my symptoms from the highest quality education and information that I could possibly get, because I would know what I was working with. The mystery would be solved. So this is critical that you understand this about the cerebellum. So the way that we are going to talk about the different damage that happens in the cerebellum is through those physical symptoms, cognitive, and mood. And we're going to get to those in a minute. One thing that's really important that we talk about with strokes is what are the initial presenting symptoms, because this is part of the education, right? We want people to understand. So the cerebellum provides us with some concern about what we call the presenting symptoms. So the very first things that happen to people, because the symptoms can be relatively vague and generalized. So what do I mean by this? Some of the primary symptoms of cerebellar stroke are headache, dizziness, and vertigo. So when people are having these symptoms, the number one problem is they themselves might not realize how significant those events are, and they may ignore them and not bring themselves to medical attention. How many of us have had a headache that turned out to be nothing? You take your aspirin and, take a nap and it's over. But the other problem is that even when people get to medical attention, there is an unfortunate tendency to get misdiagnosed as having something like a migraine headache or a stomach flu, because headaches and dizziness and vertigo are a lot more common in non-neurological issues than they are in neurological. So we need to know what's going on so that way we can advocate for a loved one if we find ourselves in an emergency situation. The other problem is that in emergency medicine, when it comes to the brain, what almost always happens is that people get a CT scan. So in the world of neuroimaging, there are basically two types of scans. So we've got the CT scan and the MRI of the brain. CT scan we kind of consider to be quick and dirty, right? It's cheaper. It can happen in a relatively short amount of time. In a medical emergency, you can kind of get people in and out. The problem, though, with the cerebellar strokes is its location. There's so much bone around the cerebellum that what you find in the scans is you're getting a lot of almost like flash that's coming from the bone, and it kind of obscures or hides the structure that it is that the doctors want to look at. The problem, though, is MRI, A, way more expensive, B, takes a lot longer, but it really is what needs to happen. Sometimes when people are neurologically unstable, this is not an option. So it's not a matter of not getting good care. It is just a matter of emergency medicine. People are kind of doing the best that they can. So when those symptoms, the vertigo, the dizziness, and the headache, are the only presenting symptom, this also tells us that the stroke is going to be isolated in the cerebellum. The other type of presentation that happens is that people can have an alteration in their consciousness, which either means they're kind of lethargic, they're kind of in and out of it, or they can be completely unconscious. This is usually due to two things. One is because the cerebellum is so far in the back, the next structure underneath it is the brainstem. What happens in the brainstem, of course, is some of our most vital body functions happen there: respiration, heartbeat, all these very important things. So if you get too much blood in the brain, or you start to get swelling, what you're going to see is maybe it's going to, what they call, herniate backwards, and basically you can think of it like suffocating the brainstem. So when that happens, that's a medical emergency, and people usually have to undergo some type of neurosurgical procedure, which is either a decompression through a craniotomy or a shunt placement. About 50% of people with cerebellar strokes present with just nausea and vomiting, and at least 75% of people present with dizziness. The impaired level of consciousness only happens maybe in about 25-26% of people, and 3% of people are brought to the emergency room already in some type of coma. The potential causes for a cerebellar stroke include cardiac emboli, so people who get a blood clot in their heart for a variety of reasons, atrial fibrillation, a hole in the heart, and it eventually travels up to the blood supply that fuels the back part of the brain. Of course, we have dissections that unfortunately happen to people where a blood vessel, basically the seam of it kind of splits open and you get blood. But we can also have things that make the blood too thick and kind of hypercoagulate. There's also a significant risk of cerebellar strokes after cardiac catheterizations, which is important to know. Let's talk about the function of the brain. How about that? The function of the cerebellum. So we talked a lot about structure, and I hope you understand it a little bit more now. The way I want you to think about the cerebellum is that its job is to coordinate two things: the timing and the force of action. Now that action can be physical activity, it can be our speech, our word finding, or it can be our mood. But really it's the great modulator in the brain, and that's probably why there's so many neurons back there, is because it has so many jobs in terms of everything we do that is coordinated. And if you start to think about the brain in that way, you start to realize that so much of what we do is a coordination. So me speaking to you right now, hopefully with some degree of fluency and comprehension, is because I'm coordinating my thoughts and my speech at the same time. That is a problem when you have a cerebellar injury. So when things are working well in the cerebellum, we have balanced movements, we have flow of thought, flow of speech, and flow of our emotions. So let's start to talk about those physical symptoms. So what I want you to understand is that movement does not originate in the cerebellum. That comes from other parts of the brain. But what the cerebellum does is it basically does a lot of trial and error to get it right. So anytime that you were learning to ride a bike, that you were learning to hit a baseball with a baseball bat, your cerebellum was working in overtime. Most movements that happen in the body, we don't think about this until there's a problem, but there's many things that have to come together to get a smooth flow. What you can see in cerebellar injuries is that movement is basically broken up into little tiny parts. So the fluidity, the flow of movement, of speech, of thought, of emotions is where the nucleus of the problem lies. So I thought it would be kind of interesting for us to all see our cerebellum in action. So I want to do two things with you all now so we can kind of see exactly what the cerebellum does. So I want you to put your arms out to your side, and I want you to very slowly with your pointer finger come into your nose. So when your arm is outstretched, so imagine that's my arm, the cerebellum is really kicking in right about here. And the idea is that if you have no cerebellar injury, you should be able to go very, very quick to your nose, and it should be very, very smooth. If you have a problem, what you're going to see is as soon as you get to that end point, you're going to start to see an intention tremor. So the cerebellum is really kicking in when the fine tuning of movement needs to happen. You can also put your hands out like this, and you can kind of just try to tap your hands back and forth like this. I'm able to do it smoothly because my cerebellum is working pretty good. What you see with people who've had cerebellar injury is that it's just not coordinated. And when we get to the rehab suggestions, we're going to get ourselves back to that, because when we know that we're really zoning in on that part of the brain needing to work, we want to exploit that for the very best rehab recoveries that we can get for people. What you see in terms of problems with motor function after a cerebellar stroke is a set of symptoms that falls under the heading of ataxia. So what this means is it's a loss of the full control of body movements. And the main way it comes out is in balance, posture, and the coordination of voluntary movement. So things like walking. So again, think of everything you now know. What the cerebellum does is it takes together a lot of parts, and the output is nice, smooth motion movement. When you have a cerebellar injury, it's almost like staccato. You know, it's not coming together as a fluid whole. So we see things in little bits and pieces. We also know that the coordination of eye movements is located in part in the cerebellum. So that's why a lot of you have had double vision. You can get very overwhelmed in terms of visual stimulus. There's a lot of headaches that go along with cerebellar strokes, and it's because one of the most significant reflexes for stabilizing the what we call retinal image in your mind when your head moves is not working well in cerebellar stroke. So we don't even realize, it's totally unconscious when your cerebellum is healthy, that your head and eyeballs are coordinating constantly to try to accommodate for the fact that your head is moving and things in your environment are moving. That reflex is not working well when you have a cerebellar stroke. And you need to know this because things are going to visually overwhelm you, especially things like being in a car when there's a lot of input coming at you. And forget it if someone's also trying to talk to you at the same time. It's very overwhelming, I would imagine. Now we're going to talk about the cognitive symptoms. So again, don't forget, we're talking about the great modulator here. So it goes for the physical symptoms, but now we're going to start to talk about the things that are less known, less commonly understood. So remember what I was saying before, that in the cerebellum, we get these crossed brain tracks, right? So right cerebellar issue is going to give you left frontal lobe effects. And this is where most of the research is, and it's really interesting because the incidence of right and left cerebellar stroke are pretty much the same, but right cerebellar strokes get a lot more face time in research, and probably it's because we're such a verbal culture that we are really noticing output problems in the left frontal lobe. People with the left cerebellar injuries are going to have problems in that right frontal lobe, but you know, that's the so-called spatial hemisphere, the silent hemisphere, and so we just can't access what it's doing as well. But most of the research is done with right cerebellar injuries. And what we find is that over time, when people haven't had good rehab, you're actually going to lose gray matter, brain matter, in that left frontal lobe due to lack of stimulation. And this is why I need to talk to you about not just doing physical therapy, but you also need to be doing cognitive therapy, because we have to get that part of the cortex stimulated. We also know that there is a difference in language symptoms in these right cerebellar strokes. So the two things you're going to find are what we call dysarthric speech, which is just not fluid speech, up and down, kind of a little bit jerky speech, and we're also going to find word finding problems. I wonder how many of you out there who have these strokes have struggled with finding your words, because that would be a very, very common symptom. This is going to also apply to mood. So this maybe is, to me, some of the most helpful conversations that I've had with people with cerebellar injury, is explaining to them how it is normal for their emotions to change. And really, it's the feeling of the emotion that seems to change. So the emotions coming on very, very suddenly and very intensely, but also leaving as quickly as they came. So kind of like capricious mood, right? It's this way one minute, the next minute it's not this way. You're crying at a movie one minute, the next minute you're wiping the tears away, and you're pretty fine. It's gotten a lot of attention in terms of anger and irritability and sadness, but I think the truth is that's probably more related to what's going on in your mind and in your spirit post-stroke. It's not the happiest time in your life, and so I don't think it has so much to do with the negative emotions as it does your brain is just not as able to hold back on the intensity of the feelings of the emotion. There is something called PBA, pseudo-bulbar affective disorder or syndrome, and I'm not a huge fan of that label, only because there's so many symptoms that could fall on the spectrum of emotional dysregulation, and I personally find that to be a much more helpful way of talking about it. The other thing is they've come out with a medication for PBA in the last couple of years, and I see way too many people taking it, and it doesn't really seem to help them. So it's gotten a lot of press, but I think that's kind of a pharmaceutical thing. So, you know, they have a drug for it, so now let's talk about it as a problem. I see it a little bit more on the spectrum of happens to most people following a stroke. Probably people who have frontal lobe injuries directly and indirectly are having this a little bit more, but there are some good strategies for it, so we'll talk about that. We have to talk about cerebellar cognitive affective syndrome if we're going to talk about the cerebellum. This was really pioneering work that came out of Massachusetts General Hospital during a time when I was up there living and training. And really, it was the first series of research that validated that the cerebellar's functions go beyond motor symptoms. And what they really talked about is everything that we've already talked about tonight. And of course, I've learned so much from the two researchers, which is that brain injuries result in layers of symptoms, and it's going to be that physical, the cognitive, and the mood. So they really put the cerebellum on the map in terms of just non-physical symptoms. So let's talk about outcome after a cerebellar stroke. Well, first of all, there's not a lot of research articles out there, which kind of bummed me out. In general, people with cerebellar strokes are actually thought to make pretty good recoveries, which is nice. There are 3 factors that are unique to each person that seem to be most related to how well someone gets. The first one is the level of consciousness that they presented to the hospital with. So the people that were in the coma, that were kind of subconscious, those people tend to do worse in the long term, and that's probably because of that brainstem getting involved, and those are the people that are much more likely to need the surgery, which really is in and of itself its own type of traumatic brain injury. Of course, it's life-saving and it's needed, but that's a big education piece that I like to do with my patients, which is if that's happened to you, you really had 2 traumatic brain injuries. So there's the stroke, but we also, of course, have to cut through healthy brain tissue to get to do the evacuation, and that's going to, even though it helps you, also give you some additional trauma in your brain, which has implications. The next one is actually the location of the lesion or the stroke, and the next one is size. That's really interesting because you might think the bigger the stroke, the worse off people are long term, but actually it's the location that is most influential. The other thing, and this goes for all types of stroke, is the age of the person when they had the stroke. Younger people tend to do better in terms of reorganizing their brain afterwards. The health of the rest of the brain. A stroke is a focal injury. You have the whole rest of your brain to compensate, and so the ability of the rest of that brain to compensate makes a huge difference. Access to rapid medical care, the intensity of your rehab, the social support that you have, the quality of the insurance, the medications. There's so many different factors. Let's talk about rehab. This is maybe why most of you are here tonight. My general philosophy on rehab is that everything that you do should be rehab. Rehab cannot be 1 hour at the physical therapist. It cannot be 3 hours with OT, PT, and speech. Every single thing that you do in your life, I really want to encourage you to think about through the rehab lens. There's one danger with that though. As a psychologist, I don't want you to have your whole identity and everyday life consumed by the fact that you have had a stroke. Yes, this is a new part of yourself and your life, but it is not your whole self. The idea of seeing everything as rehab should really come from an empowering place, that everything that you're doing is through self-care and commitment to yourself and your family to get you back to as good as you can possibly be. Physical therapy is unbelievably important when it comes to rehabilitating cerebellar injury. What we know is that over time, tremors get better and the jerky, uncoordinated movements get better when people have intensive rehabilitation. There were 2 studies that I read about that were new to me that I wanted to share with you, which is kind of one of the funnest things about doing these lectures is that I kind of freshen myself up on the topic. There was a really cool study that came out last year in the Frontiers of Neurology, and it was just a pilot study, but what they had people who had cerebellar strokes do was do a walk therapy program, which is awesome. I just recently saw a really great woman walking in Seagirt, New Jersey, which is about 25 miles from where I grew up, and she was saying for the last few years she gets out on that boardwalk and she walks and walks, and first it was with a walker, then it was a cane, and now she's walking independently, and it was so awesome to see. But what they suggest is actually walking to a metronome. So the idea is that this will decrease the variability in steps and make things more coordinated over time. Now, a metronome is something musicians use to make sure they're right on the beat. And you could definitely use a metronome, but you probably could also find music that was actually very, very structured and was, say on the 4 or the 5 beat. But what they found is that people actually got significantly better with the fluidity of their walking when they did it to a very specific beat. I thought that was interesting. So remember before when I was showing you the moving the hands up and down and doing all those little movements? That is some of the most important thing that you can do for yourself during the day is fine motor skills of grasping over and over again, touching your fingers, simple things, moving your hands up and down like that, doing specific patterns on your hand, even rock, paper, scissors, anything that you can do that is a couple different steps that you have to coordinate. When you're just sitting there watching TV, you should just be working the affected side over and over and over again. Vision therapy is incredibly important with cerebellar strokes, and not everyone gets it. So please, prism glasses can help. It can really help to decrease headaches, get people back to driving and working. It can be really, really important. Cognitive therapy, not cognitive behavioral therapy, but cognitive therapy, speech therapy that is focused on word finding and fluency of speech is very, very, very important. I was trying to think of something people could do at home that, my whole thing is free, low cost, right? I don't think rehab, above and beyond having insurance and access to those resources, should necessarily be an expensive thing. I typically don't believe in supplements. I'm a very critical audience for a lot of the brain fitness industry. There's just so many things, once you know how to do it better, you can do yourself for free. And so I was trying to think of what I could recommend. And actually, I think word searches would be really good, because you're kind of getting a triple benefit. So you're going to get that visual search, you're getting fine motor skill by going in, and it's verbally based. So what you want to do with all rehab is start where you're at and then progressively push yourself harder and harder. And what I want you to do is find that sweet spot where you're almost frustrated, but you're still able to keep at it. That's when your brain is starting to recover and grow new little dendrites, and then those little guys want to communicate with each other. You have to push it. If you do it too hard, though, you're not going to get the reward of seeing things change, and you might give up. If it's too easy, you're not pushing your brain cells hard enough. So you got to find that sweet spot. Thinking about the mood symptoms, especially those emotions coming on really strong and then going away, I have two different suggestions for you. The first one is to learn your triggers. Nobody can know better than you what are the things that make you get very emotional. Now, I should say also, getting emotional isn't a terrible thing, but if it bothers you, if you feel like I'm embarrassed by it, if it keeps you from being social, going back to work, what you can do is minimize your triggers, okay? The second thing is, and this actually came from my colleague, Dr. Ward, before this talk today. I was picking her brain about any pearls that I could share with you. And she said the best thing she ever learned is a form of distraction where if you find yourself in the midst of big emotions, is actually asking yourself, what color are my shoes? And it's kind of funny at first, but there's really good theory behind it. If you are a loved one and you're seeing someone starting to, get really, really emotional, you can say to them, what color is your shirt? What color are your pants? What color is this cup? So the idea is that question is very unemotional. It's not provocative at all. It's not a trigger. So you're going to get distracted. You're going to get unstuck from whatever it is that's triggering you, and hopefully get grounded back into a little bit more of a baseline. Of course, counseling is very, very important. I'm a huge fan of recognizing that a stroke is a traumatic event. If you didn't see my last lecture, I would really love for you to check it out, because I think that it's validating and it shares some very, very important information about recovery. The next two are the importance of sleep. You are going to get so much benefit out of a really good night's sleep. Sleep is so important after a stroke for two reasons. One of its functions is to help you process emotionally traumatic experiences. So I always talk about it like it's free therapy. The other one is when you are sleeping, when you are in deep sleep and REM sleep, your immune system is going wild to retrieve all of the junk that's in there from the stroke, especially blood, and it needs to get out of there in order to heal properly. So what would be really awesome is to do a really intense physical therapy session and then take a power nap. When you sleep, part of what your brain does is it actually replays motor programs or physical activities that you did in like a routine or a repetition over and over and over again, and that's how we learn. There's some really interesting research about that, but keep that in mind. The last two are you need a care team. You need people that are monitoring your progress, that are helping you see the baby steps. You need to be positively reinforced. My wish for every person who's had a stroke is they would have a caring neurologist, a neuropsychologist, a physiatrist, an excellent physical therapist, an occupational therapist, a neuro-ophthalmologist, vision specialist, and a speech and language therapist, and of course, a very, very supportive social network. Rehab never ever ends. That whole idea that your first year is your window is total BS. Then they extended it to 2 years. That's total BS. The truth is you will be recovering from this stroke for the rest of your life. And you have a lot of control over your attitude and the level of intensity that you choose to go at your rehab with. So I hope that in some ways this is a motivating talk, because you need to know what it is you're supposed to be working on, right? So many people here like, stick with it, keep going with your rehab, but what happens when you get discharged after 8 sessions? You maybe have 2 pages of exercises, but that's not really an optimal rehab program. So that's part of why I'm here. I'm trying to kind of help from a distance. So don't forget, we're gonna do 3 more sessions of our stroke series. Thank you guys so much for being with me. If this feels like something that was helpful, I would love for you to share it, like it, leave me a comment, let me know what is working for you about these talks. I very much appreciate the opportunity to be here. It is truly a privilege. Thank you guys so much, and I'll see you next week. Bye-bye.